Okay, so hello everybody, welcome to this month's Heart Muscle Talks on behalf of International Cardiomyopathy Network. My name is Perry Elliott and it's a great pleasure for me today to introduce today's speaker and my co-chair. So the speaker is Dr. Savvatis from Barts Health, who's going to be talking to us today about cardiac outcomes in mitochondrial disease. And my co-chair today is Luis Lopes from, but also from Barts and UCL. So Kostas, welcome. And we're really looking forward to your talk.
Thank you, Perry. Thanks and for the invitation, for being here. Let me just share my screen. All right. I hope you can see my slides, all right?
Yeah.
All right. So I'm very happy to present our data on our recent paper in JACC on the cardiac outcomes in mitochondrial diseases. On behalf of all the co-authors, and you'll see in the end, it's quite a few people that have put a lot of effort in that. So really, when we're talking about mitochondrial disease, we're talking about conditions they're systemic conditions. They are due to mutations in the mitochondrial DNA most of the time, so about 70% of the time. That's more common really in adults. And obviously there is a much linear inheritance, but we do have some nuclear DNA mutations in about 30% of the cases as well, and some of the genes that are responsible for managing the mitochondrial DNA and the mitochondria. Now, we know from work before, cardiac involvement is common in patients with mitochondrial disease. About 30% of the patients that do present with some form of cardiac involvement. And obviously they can have adverse cardiac outcomes, and this may involve sudden death, conduction disease, and heart failure. And the aim of this study was really to investigate the frequency of the arrhythmic and the heart failure complications in these patients with genetically confirmed mitochondrial diseases, and to try and identify some risk factors for the development of those outcomes. And obviously the patient that may be at high risk for that. We put together about 600 patients with genetically confirmed mitochondrial diseases from quite a few centers and 9 referring centers. It's a multi-center study. Most centers were in France, our center in the UK, but also in Germany, in Münster as well, in Denmark. We analyzed that this is the biggest cohort published until now. There were adult patients presenting above the 18 years of age. It was a retrospective study, and the median follow-up, as you'll see, was about 5 years. And we analyzed their first assessment and the cardiac outcomes. And we divided the outcomes into major groups: the heart failure outcome and the arrhythmic outcomes. And when we're talking about heart failure, we included death by heart failure, which is pretty common outcome, cardiac transplantation, as well as hospitalization. So really quite strong outcomes there. And the arrhythmic MACE was sudden death, higher degree AV block, sinus node dysfunction, sustained ventricular tachyarrhythmias as outcomes, major adverse event. We divided the patient groups and the genotypes in the most common one, which is the mitochondria 3243, the Miller's mutation, into the single large-scale deletions. And then, because of the frequency, obviously, we included some mitochondrial DNA point mutations and the nuclear gene variants as a separate group. That's a pretty standard way of dividing them, based on previous publications and way. And you can see here the most common mutation, as expected, was really the 3243 mutation, the Miller's mutation. So we had about 35% of the patients, but quite a few single large-scale deletions in about 30%, and point mutation nuclear gene variants following. You can see here, these are all the outcomes in terms of the neuromuscular involvement. Cardiac involvement, as expected, was about, it involved hypertrophy, dilatation, and obviously systolic dysfunction. And roughly we're coming to about 30%, which is pretty much what we know from the literature. So again, high degree of cardiac involvement defined by structural abnormalities of the heart. And quite a few patients had already at presentation some conduction defect present. Now, when we looked at the outcome, and you can see here about 10% of the patients, 9% of the patients reached the total outcome, the total MACE, which involves both was a combined heart failure and arrhythmic MACE. and that was about, and the half of it was a heart failure outcome. So 30 patients in the group and about 30 patients reached the arrhythmia outcome. You can see here we had 5 sudden deaths. We had most of the patients really were because of the conduction disease, so significant conduction disease. And there were 4 patients with sinus node dysfunction requiring pacing. In the heart failure, you can see most of the outcomes were really due to heart failure hospitalization and death rather than transplantation. We calculated the Kaplan-Meier curves for survival according to the genotypes as we discussed before, and these are the Kaplan-Meier for the total for the combined endpoint. And we did 2 things. One is from baseline for the first presentation in the center, but then as well calculated the risk from birth. And you can see here the single large scale deletions as well as the Miller's mutations and the 3243 really have the worse prognosis than the others in terms of their combined outcome. So they reach the outcome significantly more frequently than the other mutations. But you can see here the early on differentiation of the large scale deletions early on in life, as well with a bit later presentation of heart failure events in the 3243. Looking into the heart failure outcomes specifically, again, you'll see the most common mutation that reaches the outcome here is the 3243, in keeping with what we know from the literature, with a bit less involvement as well is in the large scale deletions. And actually, you can see here that the age of presentation where we normally expect heart failure outcomes is really relatively later on in life, around 45 to 50 years, and that's where the curves really start to divide significantly, again, with relatively few events of heart failure in the other 2 genotypes. And when it comes down to the arrhythmic MACE, you can see here this is pretty much a very, very single game. Really, the single large-scale deletions are the ones that have the most significant events. And early on in life, as early on as in 15, in the second decade of life, you can see here this is quite significant compared to all the other genotypes. I'll say a bit about the sudden deaths, really, because that's an event that there is quite a bit of discussion in the literature in the past about the sudden deaths. In our cohort, we had 5 sudden deaths. Most of them, they were due to conduction disease, really, rather than proper arrhythmic deaths. And the only two deaths in the Miller's mutation, and it was a patient with relatively mild phenotype who had other comorbidities and anaphylactic shock in there. So really, most of the sudden death events that we described now in our cohort in the 600 patients were mostly due to conduction disease rather than and no patient had confirmed ventricular arrhythmias. This is our multivariate analysis, and you can see all the univariate, all the parameters that were involved. But the multivariate analysis, we found relatively 4 factors, and these are the ones that we've included in our model in the end to create risk factors. You can see here the Miller's mutation, the 3243, is quite significantly correlated with the heart failure outcome, as well as the already presence of significant systolic dysfunction on the first assessment, as well as the ventricular ectopic. So ventricular ectopics were defined as more than 15 per hour, or presence of non-sustained ventricular tachycardia on the 24-hour Holter. And the conduction defects were defined as right or left bundle branch block, left anterior fascicular block, or significant first-degree AV block. And what we went on to create was a sort of a risk score divided by the risk factors. You can see here those, and this was the idea of that was to give us an idea of how to risk stratify the patients. You can see here patients that had 0 or 1 risk factor essentially had an excellent long-term outcome over the years of follow-up, whereas the risk obviously started increasing with increasing risk factors. And this is probably quite important in terms of how often we follow up patients or our management in terms of heart failure and potentially for treatment in the years to come. The same happened with the arrhythmic MACEs and with the arrhythmic outcomes. Here, as we can expect from the previous slides, the single large scale deletions were really 5 times more common in the conduction in pacing, so essentially conduction in arrhythmia MACE, and obviously conduction defects that were correlated with that, as well as impaired function, no other factor. You can see here the patients that again had 0 or 1 risk factor, for instance, just the genotype with absent other factors had an excellent prognosis over the years, whereas the patients with 2 or 3 risk factors really were the ones that progressed more commonly. So I will conclude here. So mitochondrial diseases are characterized by relatively frequent cardiac involvement, and heart failure and arrhythmias can occur in about 10% of patients with mitochondrial disease, with the 3243 mutation being the main responsible for risk of heart failure relatively later on in life. And the single large scale deletions are the ones that primarily affected by significant conduction disease requiring pacing quite early on in life. And we've developed also risk score, which is based on relatively single parameters that we can identify in clinic, and with a single test, we can identify high-risk patients who may need closer follow-up or early treatment and initiation. And I will finish that by acknowledging all the people that put a lot of effort. You can see here there's various senders and a lot of people. And thank you.
That's great, Kostas. So I mean, see a lot of people involved in it, but yeah, I think great work by you and Karim. I think it's a really important paper, this. I mean, as you say, it's a really large series, and you've generated, I think, a really important risk score, because this is a difficult group to decide what
Absolutely.
to do. So so we're open for questions. As Alex has put in the chat, please either post your questions in the chat, or if you raise your hand, we can unmute you so you can ask specific questions. But maybe if I can start, the literature is very binary, isn't it, between pediatric populations and adult populations, where the natural histories seem to be much more severe in the kids. I mean, do you think that's, first of all, do you think that's correct? And do you think that just reflects the fact that the kids are presenting with more severe disease and therefore die early? Or do you think there's something different about the pediatric form of mitochondrial disease?
I think that's always the question. Is, I mean, in quite a lot of the heart muscle conditions, and even the neuromuscular conditions, the systemic conditions, we find that people that are earlier on in life, they're actually a totally different ball game. I mean, we see that in laminopathies, congenital muscular dystrophies. We see that in congenital myotonic dystrophy. So really, there seems to be a very different phenotype. So I think that is probably true for the mitochondrial disease. I don't think we actually have that much data there, but it's probably true for mitochondrial disease as well. That is more, it's more severely affected early on in life. It probably makes sense as well. I think for the single large scale deletions, which one of the problems is because they start very early on. So really, it's the pediatric population that affects them, and this is probably the one that is associated with higher mortality. Obviously, the sudden deaths and the pacing need quite early on. So I think there is certainly a bias when we actually look at our data, maybe potentially missing patients already that potentially have passed away in the pediatric stage. So I think there's definitely that is definitely true, I think, for mitochondria as well.
And as a follow-on from that, I know what the answer to this question is, but we don't have data on the percentage of heteroplasmy and so on within these patients, do we? So we did.
No, and I think that's a great point, actually, because no, we don't. I mean, we probably will have. We can have, the urine and blood potential heteroplasmy. We don't have that on our cohort. It's not standard done by everybody, and you can see quite a few centers involved there. But it's also the question of how much is actually in the tissue, in the cardiac tissue. So it's very difficult to actually get that on. I suspect it probably plays quite a significant role how much which tissue is affected, which is also the other point of why obviously the phenotype and the is so variable in these cohorts.
Yeah. Please, what do you think?
Yeah, I think I can. I was thinking about, in terms of practical, sort of recommendation or advice or take-home message from the paper, because there's obviously, as similarly to other similar diseases, there's a lack of guidance because of rarity and lack of data as well. What would you comment in terms of the implications of this data for recommending both, starting of follow-up, interval of follow-up, and also types of tests? Do you think this data should change the way we follow these patients? Should we just keep doing the same as we are doing now?
No, absolutely. That's I think that's one of the main points and one of the main take-home messages of the paper. I mean, as you're saying, at the moment we don't really know. The guidelines are very diffuse, and every center does something different. I think one of the strong points is that you can actually risk assess the patients with relatively simple measures. So with an ECG, an echocardiogram, and a Holter in clinic, you can actually get a lot in terms of risk assessment. The other point is that patients who have very little in terms of risk factors, they have a very good long-term an excellent prognosis, and they probably will not need as frequent follow-up as other people. Whereas people who have many more risk factors, they should be more aggressively followed up and potentially treated. So I would think that I mean, this involves, even if you actually have only the genotype, which quite a lot of people will, and especially now in the modern in the modern screening times, there will be a lot of people that we pick up for screening for family history. And if they actually have just the genotype and they don't have other risk factors, then we can be a bit more relaxed about following up. I mean, obviously, this data need to validate it in larger cohort, in other cohorts, and potentially, make sure that everything is as we're saying it is. But I think, it gives us a reassurance that, patients who have a low amount of risk factors, they will not be as much as risk as before. And I think the other important point is because it's always about, risk of, the question about sudden deaths, and we always find it's a very difficult cohort. And I think, from time to time, we are a bit concerned about, sudden deaths in this patient population. And obviously, there are some people with very extreme phenotypes, like the ones that you published in your paper. And those, obviously, there is still probably a risk of sudden deaths, but these are quite rare, and usually easily picked up again on imaging or other factors. Yeah, so in our cohort, probably the sudden deaths were not as many as we expected, and certainly not really.
So I wanted to challenge you on the single risk factor thing in a minute, but Jacopo, you raised your hand.
Well, thank you for a very nice paper. I enjoyed the paper. Yeah, a couple of things is, first of all, we mostly have MELAS patients, but of course you get a bunch of everything. But in MELAS, you do have a really serious problem with diagnostic delay, with a gap. So despite the fact that they, have pretty obvious features, I wonder whether that's your, opinion as well, because we tend to have referrals of patients that have been seen by like 6, 7 specialists before they come to us, and my nurse makes a diagnosis as they walk through the door. So with that is an issue, and usually the cardiomyopathy is not much of a cardiomyopathy. It's not particularly striking, and if anything, it makes you wonder, why, if you have mitochondrial disease, your skeletal muscle goes completely hypertrophic, and your heart responds with hypertrophy. So that's, I think, fascinating for research. I just want to have your thoughts about that, particularly the diagnostic delay, if you have any data on that.
No, I don't have any data on the diagnostic delay, but you're absolutely right. I mean, they do. I mean, the feeling is that they do come quite late on, and obviously the problem with the MELAS is that their manifestations. I mean, if they manage to skip the pediatric population, the pediatric time, then they are relatively mild, and they progress, usually after the age of 30, 40, and that's when they are picked up as probants. I think we are probably going into a time where, with all the screening, we're going to identify a lot of patients with the genotype and have an earlier diagnosis. But absolutely right, for the ones that are symptomatic, it tends to get quite a lot of time. I mean, I suspect the problem is in the UK as well. That is, I mean, there are rarer conditions, so they have to end up being on a relatively specific place to actually get proper diagnosis and evaluation. I always find it fascinating that, I mean, as you're saying, the cardiomyopathy is not particularly much, but I always find it fascinating how little of those we actually see random in our clinics. I mean, one would expect at least, with hypertrophy and dilated cardiomyopathy phenotype to at least pick up somebody. I cannot remember when was the last time I think once I've sent a patient to my neurology colleagues, and it ended up being a Miller's actually. The other 10 times it wasn't. But yeah, there are some extreme phenotypes. I think Luis has put a couple of extreme phenotypes in his papers. But most of the times it's not going to be a significant phenotype, cardiac phenotype at least.
Thank you. I see Eloisa coming along, so she knows much more than I do on this topic.
Yes, if I can add a comment, I would say that we have a big limitation in understanding the pathogenesis and evolution of this disease because we don't measure the heteroplasmia in the heart. This is our problem, and we are very stupid because this is feasible. This is feasible, and this would really change our way of approaching the disease and understanding the disease. So we are going around continuing to ignore the possibility of deepening the pathogenesis of MERS. In our experience, it's the same issue in which you published your paper. So we have our small series, and we have asked the help to Jacopo because we didn't have experience with children. But in our experience, the clinical evolution of patients who come to our attention for the cardiomyopathy is dramatic. It's dramatic. These patients do not have any future.
In children, you mean?
Pardon?
In children, specifically.
No, we didn't have experience. So I asked Jacopo Livotto to help me in that paper, because I didn't have the scene. I haven't no experience with children. But in adult patients who coming with heart failure, with cardiomyopathy as the major clinical trait at presentation, I would say better at the diagnosis, not at presentation, because the story of these patients dates back decades before. Hearing loss, diabetes, myopathy, everything. Probably we see the worst because we are a transplant referral center, and so we have a partial view. But we have the way of solving this problem, and this is making the measurement of the mutated DNA in the heart.
I mean, it comes back to that thing we were talking about kids and adults. The ascertainment bias here is huge, isn't it? Because it depends where the patients are coming to you from. So if they're coming through a cardiomyopathy clinic screening, you stumble across someone who's got deafness and diabetes, and you check them through a 3243. Yeah. And the hypertrophy, as Jacopo said, is often very mild, concentric, not very exciting. Yeah. If you've got sort of sick patients with severe neuromuscular involvement or respiratory involvement, they do really badly. So I think it depends where they come at you.
Where and when?
Yeah.
Absolutely. But there are conditions in which we need to take decisions about how to progress with investigation. Because if we remain on peripheral blood evaluation, we will not understand.
So Eloise, I think you make a really great point about heteroplasmy in the heart. But what I've always been confused about with mitochondrial syndromes is that you have syndromes where it sort of seems to be reproducibly limited in terms of its expression. So whether it be the classic Kearns-Sayre syndrome or Leber's optic atrophy and so on, it seems, why is it Leber's picks out the optic nerve and maybe sometimes the heart? Why is it Kearns-Sayre's is mostly a heart disease? Why is it, some of them are predominantly skeletal muscle? And so although the heteroplasmy, it should be a random effect, you do seem to have these syndromes within. And why should that be?
Yeah, this is possible, Perry, but any hypothesis we do, we need to make now some effort to demonstrate. Yeah. So we can hypothesize everything, but we can also hypothesize that there's an increase of the amount of mutated DNA with age and with time. So children may have a lower amount, and adults may accumulate mutated. Of course, this is a niche. This is a small population. But I'm not sure that it's so small if we go and start from diabetic patients with hearing loss, which is very common in this patient. In MELAS, obviously, not in nuclear mitochondrial cardiomyopathy. That's another story in my experience. So probably we need to have a very stringent plan of research and make a big effort in order to have a more clear idea on how to progress. Also for future target treatment, because I don't see future for this patient.
I mean, Kostas, you said that we're going to be making this diagnosis more frequently, but are we? Because we're not routine screening the mitochondrial genome.
No, we're not routinely doing that. You're right, but yeah, we probably should be. We're doing it more now.
I mean, or should we? Because it's a bit of a noisy beast, isn't it? It's a small amount of DNA, but it is quite noisy. I mean, Luis, what do you think? Do you think it's something we should be doing routinely?
I think inevitably will come. The noise will come with whole genome, together with other noises as well. I think we should be very careful when it comes, because it will come, and we should probably tire the analysis like we do anyway for mitochondrial protocols, meaning checking the most so-called common mutations, and that's it. I mean, if we are seeing a cardiomyopathy patients, but inevitably it will be easier. I mean, even from exome, as we shown, we can pick up the signals of for mitochondrial variants. So inevitably with whole genome that will happen, and it will be easier. But again, it requires caution.
Yeah, I don't. Looking at the people on the call, is anybody here routinely doing mitochondrial screening? Eloisa, do you do mitochondrial DNA screening when you're?
Yes, very. When the clinical data, when the clinical evaluation suggests a possible mitochondrial disease, we have, for example, 7 families in which we found the famous 4,300 variants.
Yeah.
In 6 of these families, we have a double nuclear sarcomeric mutation plus mitochondrial 4,300. So, and these are different, totally different patients. For example, they can easily undergo transplantation because they do very well after transplantation. They do not worsen. No surgeon would raise a question about this. So we have evidence about this. And I guess that we could try to focus in our network collaborations on a couple of questions. One is definitely MELAS, and another one is a model in which we have a nuclear plus mitochondrial DNA mutation, and try to generate larger series and see what is the best strategy for the future in order to develop research. So starting from pediatric age, Jacopo is following children with this variant. Kasky, I guess, probably has children also. So if we could be able to put together a group, a series of 2 different models, 2 different types of evolution and phenotype, these patients would be very interesting to me.
Yeah. So Alex is pretending to be a generalist at the moment. So Kostas, he's asked you a question here. Who are the phenotypes that we should be seeking mitochondrial DNA variants in?
Yeah, I think again that's a very different phenotype. There's so many different phenotypes in these patients, but the classic phenotypes would be, as you say, mild LVH, which may not even be coming to a cardiomyopathy clinic, because this is probably going to be lurking somewhere in the general cardiology clinic. They're going to have diabetes, hypertension, and mild LVH, and they probably will be put down to cardiovascular risk factors rather than anything else. So I think these are the typical, and then obviously if you have muscular involvement, you're going to have deafness. There are some very typical features on the systemic involvement that will can raise the flag for that. There are also the very extreme phenotypes, biventricular hypertrophy and involvement, potentially the ones especially that are gene negative in our panels, and who obviously have muscular involvement as well at the same time. Although in my experience there, it's most often the mitochondria. We think it's metabolic, we think it's mitochondria because there is some dysfunction and mitochondrial looking pictures on the histopathology on the peripheral muscles. Actually, almost never we find any specific genetic mutations, which I think this is also a very interesting patient group, that they're actually gene negative sort of mitochondrial.
Yeah. Okay, Jacobo, you put your hand up.
Just another question is are you aware of any experience in family screening, or have you done? Because I mean, what is the degree of variability within families? I have little experience, like numbers are small, but this tends to be quite reproducible in the family, in my experience, particularly the MELAS sort of phenotype.
Yeah, we think it's reproducible as well, and in fact, actually, the cardiac phenotypes seem to be relatively reproducible. The patients that have the families that have heart failure, they will have even the mom comes and the kids have heart failure. I think we limited experience in screening, so I wouldn't be able to give you the data, but that's a feeling as well, that there is a certain degree of homogeneity in the phenotypes within the family. And actually, the neurologists mentioned the same thing as well from their side. Now, what is a bit more worrying is that there are quite a few families that sudden death seems to be relatively frequent within the same family. We're currently looking. We've got about 10 families of those now in our local group, and we're looking into them. At the moment, the signal doesn't seem to be cardiac; it's mostly epilepsy and epileptic deaths. But
okay, there's a question from yours. Any CMR features that are specific for mitochondrial, do you think?
Yeah, I think Luis may be more appropriate here, but generally, biventricular hypertrophy, extreme hypertrophy, I guess, especially with ECGs that look very, very metabolic, very diffuse fibrosis, and especially also in the non-hypertrophied areas. I think that probably features from the MRI. Again, that doesn't always. It's very non-specific, I would think, but quite often it's the one that you think this looks metabolic, essentially.
What do you think, Luis?
I mean, Costa said almost everything. Most of the things would be picked up by an echo as well. So the concentric pattern, the systolic dysfunction, all of those things. What MRI could potentially add, which is the scar, we did look in a lot of actually these patients from the same cohort that was published in this paper. And to be honest, most of them, even with a cardiac phenotype, don't have much scar if the phenotype is mild. When it's not mild, you tend to have extensive scar that could have really any pattern. There is very little literature on it. Probably the best paper is from 5 years ago or more, published in JCMR. But there's really no consistent pattern that could be, we could say it's more typical of the 3243, of the 4300, or the 8344, so the different, cardiac specific ones. We do have a cluster of patients with quite a severe phenotype with the MERF mutation, with the A344. But even there, for example, in this, our other paper, we saw similar patterns with 3243, so it's very non-specific. I think the important red flags are the ones that Kostas mentioned and are beyond or before SCAR, together with the ECG and the extracardiac features.
Yeah, I mean, the ECG I think is important. I mean, I think conduction disease in someone with mild hypertrophy, I think, it's that list of about 4 or 5 things that drop down, isn't there? And mitochondria is definitely one of them. And in the past, I mean, I'm not sure it's because I've got out of the habit of doing it, but I used to occasionally pick them up using the CPET. So you'd have someone who has what appears to be relatively mild hypertrophy, no outflow tract obstruction, but significant impairment of peak VO2 with sort of hyperventilation because they're developing premature acidosis and a sort of disproportionate heart rate response as well. And I mean, I haven't seen one of those for a while. Is that something that you've seen any of these patients? Or?
Yeah, so high respiratory, so high RER above 1.4. I picked up one recently. There was a chap who actually came with Luis had done his MRI actually, and he even mentioned the metabolic profile.
There we are.
Metabolic MRI. So there must have been something very specific. But this chap had rhabdomyolysis every time that he was going hiking above 2,000 meters. And he did it a couple of times, and I think that and his CPET was consistent with that. So I think that's you're right. Absolutely.
And he was mitochondrial, was he?
And he's a Miller, yeah.
Interesting, because the rhabdomyolysis is often, for me, feels more sort of fatty acid or sort of CPT deficiency, carnitine transporter kind of problem. That's interesting, but I think the CPET there is valuable diagnostically.
Absolutely.
Yeah. So, coming back to your point about the single risk factor patient. So, do you think all the risk factors weren't equivalent, were they? Because I mean, low ejection fraction carried I think it was an 11-fold increased risk of bad stuff.
Yeah,
and similarly, conduction disease, again, not a good thing to have. So, is it just that if you've got an impaired LV function, you've got all the other stuff as well? So you rarely see just an impaired LV function.
Yeah, I think that's how it comes. So the problem is, I mean, obviously in the other genotypes, it's very difficult to I think there's some phenotype homogeneity within the Millers and within the single large scale deletions. And usually when you have those, you're either going to expect the impaired function or you're going to expect the conduction defects respectively. And so these things generally will come together. It's much more difficult to actually know what's going to happen in the other genotypes, where obviously the data are very, we have 1 or 2 patients from each specific genotype. So I think in those populations, probably much more difficult to actually see, to see what the effect is and especially the risk factors. But I mean, I think these things they come together essentially in the risk factors. So you're going to have a Miller's and you're expecting that. So I think that's definitely right.
Just to recreate our MDT, so you've got a patient who's got mitochondrial disease. They've got type 2 AV block. QRS is 140 milliseconds. What kind of device are you going to put in?
What is genotype?
3243.
3243. Yeah, I think you're absolutely right. In RMDT, we've discussed quite a few cases of those. I don't think we actually have at the moment the evidence that we need to put a defibrillator, unless the phenotype is really extreme. There's a lot of fibrosis, and you're going to need to put. It sounds like a patient has very advanced conduction disease, and very likely to need a device very soon. So I think unless the phenotype is particularly extreme in terms of hypertrophy, fibrosis, potentially malignant family history, I would think a simple pacemaker would be fine.
Jacopo, if you're there, what do you do when you have to put a device in? Do you go for a pacemaker? Do you go for a defib?
It's tough. I mean, it's tougher when you have Duchenne disease, or in general, this really depends on what the outlook is. If I think the patient has a good prognosis, I mean, it has rarely occurred to me to have a patient with a malignant sort of arrhythmic profile. Again, because of what I was saying. If the child is very small, it's severe disease. It's usually not the heart that kills the patient. It's more the chest infection. It's extracardiac complications. Older patients, again, I've not come across a lot of high risks of supposedly high risk patients. So, it's a tough call. Of course, if you need a device and the life expectancy is longer than a couple of years, which usually is, then you discuss very openly with the patient. I do this with virtually any cardiomyopathy now. We used to equate pacemaker equals ICD in anyone who needs a device with a cardiomyopathy. Now I'm really much less aggressive, even in HCM, for example. So if you need a pacemaker, you often end up getting a pacemaker unless you have other features. In here it's like no data-free zone, so hard.
So often, yeah. Luis, what's your feeling about the pacemaker versus ICD question?
It's the same as Kostas was mentioning too. I think the actual phenotype will make us decide one way or the other. It's a bit like we do in other rare data-free patients that we often discuss. Fabry, for example, is one. Myotonic dystrophy is another big query, which is not solved yet. And then considerations around the actual general status and so on, as Jacopo was saying, are always quite important. It's tough for mitochondrial disease. There's so much variability. And like Kostas was asking, what's the mutation? There's also quite it's variable also in terms of type of mutation. Again, sometimes we get an SVT in Holter's. We don't know what to do with it. That's another thing. By the way, an SVT didn't come up as even in Univariate or whatever.
It was part of the.
I can't remember.
It was part of the PVCs, either lots of either non-sustained VT or ventricular ectopics. So it was more than 15 per hour, which is somewhere around 400.
Which ended up on the heart failure model, not on the arrhythmia.
Yeah, that's the interesting bit. It's more on the heart failure model rather than on the arrhythmia MACE.
Jacopo, then Max.
Oh yeah, I agree. I mean, this myotonic dystrophy is more scary to me. So I tend to be more aggressive there than Friedreich's ataxia sort of stands in the middle, and mitochondrial disease is sort of the milder end in my experience. Again, if you have one event that changes your experience, it's almost 100%. So
the thing is that I mean, the myotonics are tricky, aren't they? Because we know they do get ventricular tachycardia and VF, but often that's really quite advanced disease, and I still think the majority of patients die from the results of their neuromuscular disease with bulb palsy and aspiration and recurrent pneumonia, etc. Max?
Veering back to the mitochondrials and the pacemaker versus ICD question, while it may be a data-free zone and the numbers are small, the impression is different from, for example, the Lemon story where patients used to get pacemakers and then die suddenly. So we're not seeing that, are we? So although there's absence of data, there doesn't seem to be, the impression is there's not a high risk of ventricular arrhythmias in these people.
I think it's true. I mean, Kostas, I think your data show that there's not a very high risk of sudden death, full stop, in this population. Isn't that right? Or I think we're quite reassured by the data in terms of, certainly for ventricular arrhythmias, we've got a good number of single large scale divisions who've got devices in there, so we actually know their outcomes very, very well. So they don't really die from ventricular arrhythmias. And the ones that we're worried about are probably the ones with very extreme phenotypes where, then we don't know what it is. But then again, usually they're quite significantly affected also from, central nervous system as well as muscular disease.
What about the risk of atrial arrhythmias, AF?
Yeah, we don't see that often as well, apart from those with extreme phenotypes. And when you actually start having a lot of left ventricular dysfunction, I think that's it's pretty standard as in other forms. I would think. I mean, bear in mind that also these patients have a lot of comorbidities. I mean, they've got diabetes, they've got hypertension, very, very standard. So that may affect them from that point of view as well.
Yeah, but it just tries to. I haven't really thought about it before, but I don't think that they don't seem to be, the atria don't seem to be quite as twitchy.
No, and they're not big either. They're relatively small as well. Yeah.
Eloisa, is there anything different about the mitochondria in the atria from the ventricle? I'll let her think about that question for a while. Okay, so I think we've got some important red flags for diagnosis. In terms of routine monitoring, what would you recommend?
I think most of the patients that will come, if they have low risk factors, usually and I mean obviously bearing in mind that this data still need to be sort of validated and reassessed in the long term of whether what we're doing is actually right. I would think the low risk patients, every couple of years, every 2-3 years, they're absolutely fine. I'm sure we probably can push it a bit further, but for the rest, it's probably going to be at least annual follow-up.
Okay. So Eloisa, a very specific question to you. So mitochondrial disease in the atrium versus the ventricle, is there any difference? What are the atria like?
In the tissue?
Yeah.
In terms of amount of mutated DNA?
Yeah, I mean, so this comes just from a pure speculation during this conversation that we don't seem to see very much atrial arrhythmia in mitochondrial patients.
Not so common in our experience, atrial arrhythmia study, and not so common the conduction disease. I was expecting for more wall Parkinson White, more pre-excitation. We actually seen a very few cases. So I'm not sure because I did not investigate hearts with the MELAS at transplantation simply because we didn't transplant these patients, they died. And they didn't have an autopsy. Vice versa, I investigated the hearts of patients with the hypertrophic phenotype and double mitochondrial for 4,300 plus sarcomeric mutation. And in that case, I didn't see much differences because with that mutation, the amount of DNA, mitochondrial DNA, mutated DNA is about homoplasmic.
Yeah, exactly. That's the thing about that variant.
In ventricles, so there's not many differences.
Yeah.
It's very interesting to know about this is an interesting question, but in our experience, I don't know, we didn't see important issues with atrial arrhythmia. Not at all.
With I mean, I'm sorry, the 4300 I like. It's one of my favorite mitochondrial mutations. So
really?
yeah, it is. It So, I mean, Luis, you said it wasn't a consistent phenotype. I think most of us have had a fairly consistent phenotype, haven't they? Yeah. So start off with concentric hypertrophy, posterior wall scar, thins. A lot of them are like that. If not all of the ones we've seen.
Yeah, these ones are very consistent, I think.
The 4-3, the 4-300, but they are exceptional in every way, right? Because they affect the heart only. It's there's this homoplasmic as well, so that makes up a very good explanation for consistency there, because they have this odd thing of being always homoplasmic.
This is true.
And Eloisa, what's the future for mitochondrial DNA variants? Can we imagine mitochondrial transfer? Can we imagine what's on the horizon?
There are new hopes in pre-implantation, pre-natal, but I don't trust this information, these novelties, because if you consider how difficult it can be to measure the number of mutated mitochondria inside of an oocyte, theoretically, you can consider some sort of pre-natal or pre-implantation or whatever pre is. But once you have a baby, you never know how the amount of mutated DNA in the different organs and tissues and how to make correction. I think it's very difficult to think of corrections of the disease. I don't know. It's probably better think of a molecule that can eventually contribute and modify the mitochondrial metabolism and so on. But I'm not sure that we can think of making correction of mitochondrial DNA. I don't know what is your opinion, but to me, it's very far from my capacity of imaging.
Kostas, do you give your patients coenzyme Q10?
No.
I'll leave it to the neurologist to decide, but
the neurologists do, right?
Yeah,
most of the time.
It's a great placebo medication.
Really expensive.
It is very expensive, actually. Yeah.
What would be very important in this setting, is to prevent the stroke-like episodes. Because these are the major reason why there's no hopes there for this patient.
What's the pathology, Eloisa?
The vessels are not affected. It's just an infarction, a brain infarction, but you don't see any sorry, Perry, I'm between a
Attenzione!
Attenzione, yeah. He said ciao, Vittorio said ciao. It's just a malastic necrotic in area, there's nothing different and special and specifically characteristics in this stroke, in this material, in this brain, different from other types of. What I don't know is about the amount of mutated mitochondrial DNA in the brain. This I don't know. But that would be very important. How to prevent a stroke? How to prevent a stroke? Because this would give us much more time, more space, more probability of dealing with our cardiomyopathy. But once you have a stroke, one after the other.
Yeah. Kostas, did you recall data on strokes in that series?
The patient is
No, I'm just trying to think now because no, we've got the amount, but no particular correlation to. No, I don't think we've actually got all the data on stroke-like symptoms.
Okay.
Yeah,
Yeah,
have you tried anything like shifting the metabolism to glucose, like with paraxylene or trimidazidine? Do you know anything about that? Because that could be, I'm not sure anybody's tried it.
I thought you were going to say ranolazine then, but
No, that doesn't work. I mean, ranolazine is different. I mean, trimidazidine, right? Trimidazidine or paraxylene in this case.
Yeah. A long time ago, we tried, for patients who had predominantly complex 1 deficiency, we did try thiamine. And I made one patient go manic with thiamine. But then the effect seemed to wear off and it didn't seem to make much difference to exercise tolerance and so on. But that was twins, I think, with a 3243 mutation, but they also had severe metabolic acidosis. So they were breathless just walking across the room because our lactates would go from 1.5 to 8, just doing relatively mild exertion.
I wonder whether, rather than boosting mitochondrial function, it'd be wiser to try to shift.
Turn it off. Yeah. Yeah.
When you correct the acidosis, you don't make any prevention in any case.
No.
I correct the acidosis. Probably the risk of stroke is less than, is minor, is decreased. Not true. At least I don't know, but I don't have this evidence. So even correction, the metabolic effect probably does not exert a preventive action. Probably it improves the muscles, it improves the general status. I don't know, Kostas, what you think about, but the lactic acidosis is an important contributor of the worsening and progression, but you can't prevent anything, even correcting the lactic acidosis, at least in our experience.
Many of the patients you followed, Kostas, had lactic acidosis. I mean, do you see or suspected?
No, I mean most of them no. They don't really get to that stage. No. They may have high lactate for a while, but on diagnosis and random blood tests, but generally they don't get that much.
Yeah.
Would expect more with I mean, as you said, with fatty acid metabolism and issues. And
so, Alex, I don't know, Luis, can you see that question? He's posed you a question.
Yeah, I can see that. I mean, it's not done. So basically, I guess, does everyone have access to the questions, or shall I
repeat the question? No.
Yeah. So Alex was asking if basically mitochondrial DNA was ever used as part of the GWAS approach, I guess, to try to look for a modifier effect of mitochondrial DNA in other phenotypes. So the answer is no, because the GWASs are done with nuclear DNA, but it's a very interesting idea. And there are groups looking with more fundamental work into the potential of or the disease modifier potential of mitochondrial metabolism, and particularly in HCM. I know there are some functional studies happening. So this idea about variation of mitochondrial DNA might be interesting. But I guess it will be very challenging, again, to interpret because the current statistical tools and so on are all based on nuclear DNA only. So it's an interesting concept.
And even with the nuclear DNA GWASs, I mean, are mitochondrial genes adequately covered, do you think?
They should be.
They should be. If you use whole genome or whole exome, right?
Yeah.
So you don't get, I mean, you don't get many hits. You do get sort of energetics, you do get some energetics. You get heat shock protein always comes up as a modifier of disease phenotypes, it seems to me, in every disease. But we don't seem to get hits in, succinate dehydrogenase or whatever. So any of the genes.
Yeah, true. Yeah, and heat shocks are more for DCM, right? But yeah, could make sense.
Okay. Right. So I think we've come to an end. Kostas, thank you. I mean, great presentation. I think really interesting discussion. Rare disease, but I think as implied several times during this presentation, probably missed often in clinical practice. And I think with your paper, we've moved a little bit further along, I think, in understanding how we should manage these patients, and particularly prevention of heart-related complications. So, Luis, thank you for co-chairing. Thank you for everybody for joining in the discussion. And we'll see you again next month. Thank you very much.
Thank you very much.
Bye-bye.
Bye.